Good morning, dear students. The topic of our today lecture is Isoimmunization during pregnancy, and the lecture is me, Associated Professor Kosolapova Natalia Vladimirovna, Department Obstetrics and Gynecology, number 2. Isoimmunization is one of the clinical forms of the immune pathology of pregnancy, occurs under the condition of incompatibility of mother and fetus organisms in different antigens and leads to serious violations of the state of the fetus and newborn infant. Rhesus immunization during pregnancy is the appearance of a pregnant woman is Rh antibodies in response to the entering into the bloodstream fetal erythrocyte rhesus antigens. When organisms' incompatibility of mother and fetus at the erythrocyte antigens develops hemolytic disease of the fetus, shortly HDF, and newborn infant, shortly HDN. Pathophysiology. There are currently 29 blood groups and more than 600 red cell antigens that are recognized by the International Society of Blood Transfusion, so they are studied and known. Although some of them are immunologically and genetically important, may are so rare as to be of little clinical significance. Any individual who lacks a specific red cell antigen may produce an antibody when exposed to that antigen. Such antibodies can prove harmful to that individual if she receives a blood transfusion, or they may be harmful to her fetus during that pregnancy. Accordingly, blood banks routinely screen for erythrocyte antigens. Most persons carry at least one red cell antigen inherited from their father but lacking in their mother. Thus, the mother could be sensitized if enough fetal erythrocytes reach her circulation to elicit an immune response. Isoimmunization is actually rarer for the following reasons. First of all, low prevalence of incompatible red cell antigens. Second of all, insufficient transplacental passage of fetal antigens or maternal antibodies. You know that normally mother's and fetal blood does not mix and is bordered by placental barrier. Thirdly, maternal fetal ABO incompatibility, which leads to rapid clearance of fetal cells before they elicit an immune response. Fourthly, variable antigenicity, and fifthly, variable maternal immune response to the antigen, with some antigens provoking only minimal response. For all pregnant women, there is only a 1% chance of de-isoimmunization by 6 months postpartum, and that immunization does not always lead to erythroblastosis fetalis. The incidence of sensitization to red cell antigens at each stage of pregnancy has been studied more extensively in D-negative women. A D-negative woman delivered of a D-positive ABO-compatible infant has a likelihood of immunization of 16%. 2% will be immunized by the time of delivery, and 7% will have anti-D antibodies by 6 months postpartum, and the remaining 7% will be so-called sensibilized. In sensibilized women, anti-D antibodies are produced at such a low level that they are not detected during or after the index pregnancy. Instead, they are identified early in a subsequent pregnancy when rechallenged by another D-positive fetus. ABO blood group system. Although incompatibility for the major blood group antigens A and B is the most common cause of hemolytic disease in the newborn, the resulting anemia is usually mild. Approximately 20% of all infants have an ABO maternal blood group incompatibility, but only 5% are clinically affected. ABO incompatibility is different from CDE incompatibility for several reasons. ABO disease frequently is seen in firstborn infants. This is because most group O women have anti-A and anti-B isoagglutinins antedating pregnancy. These are attributed to exposure to bacteria displaying similar antigens. Most species of anti-A and anti-B antibodies are immunoglobulin M, which cannot cross the placenta and therefore cannot reach fetal erythrocytes. In addition, fetal red cells have fewer A and B antigenic sites than adult cells and are thus less immunogenic. Thus, there is no need to monitor for fetal hemolysis, and there is no justification for early delivery. The disease is invariably milder than de-isoimmunization and rarely results in significant anemia. Affected infants typically don't have erythroblastosis fetalis, but rather have neonatal anemia and jaundice, which can be treated with phototherapy. ABO isoimmunization can affect future pregnancies, but unlike CDE disease, it rarely becomes progressively more severe. Because of these reasons, ABO isoimmunization is a disease of pediatric rather than obstetrical concern. Although there is no need for antenatal monitoring, careful neonatal observation is essential because hyperbilirubinemia may require treatment. Treatment usually consists of phototherapy or simple or exchange transfusion with O-negative blood. CDE rhesus blood group system. This system includes 5 red cell proteins or antigens. They are C big, C small, D big, E big, and E small. There is no small d antigen has been identified, and rhesus or D negativity is defined as the absence of the D antigen. There are, however, D antigen variants that cause hemolytic disease. Some of these include weak D, D-indexed U, and partial D. The CDE antigens are of considerable clinical importance because many D-negative individuals become isoimmunized after a single exposure. The two responsible genes, D big and CE big, are located on the short arm of chromosome 1 and are inherited together, independent of other blood group genes. The C big, C small, E big, and E small antigens have lower immunogenicity than the D antigen, but they too can cause erythroblastosis fetalis. All pregnant women should be tested routinely for D antigen erythrocytes and for irregular antibodies in their serum. This need be done only once during each pregnancy in D-positive women, and this is currently recommended by the American Association of Blood Banks. D-indexed U antigen. Identification of the D-indexed U antigen may cause confusion or result in designation of the blood type as weak D positive. The D-indexed U antigen is actually a variant of the D antigen, and women confirmed to be D-indexed U positive and therefore D positive and don't need immunoglobulin. If a D negative woman delivers DU positive infant, she should be given D immunoglobulin. So if there is any doubt about D antigen status, then immunoglobulin should be given. Other blood group incompatibilities. Because routine administration of anti-D immunoglobulin prevents most cases of anti-D isoimmunization, proportionality, more cases of significant antenatal hemolytic disease are now caused by the less common red cell antigens. Several large studies indicate that anti-red cell antibodies are found in 1% of pregnancies. From 40 to 60% of these are directed against the CD antibodies. Anti-kill antibodies are also frequent. A fourth of all antibodies found are from the Lewis system. These don't cause hemolysis because Lewis antigens don't develop on fetal erythrocytes and are not expressed until a few weeks after birth. And other antigens, for example, KIT, JK, DAFI, FY, C small, E big, and to a lesser extent C big antigens can all cause erythroblastosis as severe as that associated with sensitization to D antigen. Two DAFI antigens have been identified, FY indexed A and FY indexed B. FY indexed A is the most immunogenic. The KIT system also has two antigens, JK index A and JK index B, with a population distribution as follows. JK A plus B minus is 26%, JK A minus B plus 24%, and JKA plus B plus occupy 50% of population. Here on a picture you can see pathogenesis of immune incompatibility development. If rhesus positive father get pregnancy from the rhesus negative mother carrying her first rhesus positive fetus. Rhesus antigens from the development fetus can enter the mother's blood during delivery or during pregnancy. In response to the fetal rhesus antigens, the mother will produce anti-rhesus antibodies. Firstly, M, which are too big to cross through the placenta, but later immunoglobulins G, which are enough small to cross the placentary barrier. And if the woman becomes pregnant with another rhesus positive fetus, her anti-rhesus antibodies G will cross the placenta and damage fetal red blood cells, lead to hemolysis. Risk factors for immunization. There are some risk factors and they include spontaneous abortion, induced abortion, ectopic pregnancy, full-term pregnancy until delivery, childbirth for compatibility ABO system, childbirth with present ABO incompatibility, amniocentesis or another invasive diagnostical procedures, and transfusion of rhesus positive blood to rhesus negative mother. And interruption of pregnancy is especially riskable if it happens after 8 weeks gestation. Factors associated with a previous pregnancy are, it means that factors can be revealed in female anamnesis. They are ectopic pregnancy, termination of pregnancy by spontaneous miscarriage, induced abortion, antenatal fetal death, and so on. Invasive procedures during previous pregnancies like amniocentesis, chordocentesis, chorionic villus sampling, and so on. Bleeding with the previous pregnancies because of detachment of normal or low-lying placenta, injuries to the abdomen and pelvis. Features of delivery. It means, for example, cesarean section, manual inspection of postpartum uterus, manual placental separation and removal the afterbirth. Prophylaxis of rhesus immunization in the previous pregnancy or in the postpartum period, and important information by what drugs was it done or what dose was used. Factors are not associated with pregnancy is blood transfusion without rhesus factor determination and use of one syringe by drug addicts. The pathogenesis of immune hydrops. So, really most pathological change happens in intrauterine baby's organism, and affection of red cells antigens by mother's anti-rhesus antibodies lead to hemolysis and development of hemolytic disease of fetus. Finally, it can lead to appearance of fetal immune hydrops or hydrops fetalis. And now we discuss its pathogenesis. The abnormal collection of fluid in more than one area of the fetal body, such as ascites and pleural effusion, is termed hydrops fetalis. In immune hydrops, such as that with de-isoimmunization, excessive and prolonged hemolysis causes anemia, which in turn stimulates marked marrow erythroid hyperplasia. It also stimulates extramedullary hematopoiesis in the spleen and liver with eventual hepatic dysfunction. And students, pay attention. Later we will talk about visible on ultrasound symptoms of hemolytic fetal disease, and the first appearing symptom is a hepatosplenomegaly, enlargement of liver and spleen. There may be cardiac enlargement and pulmonary hemorrhage. Fluid collects in the fetal thorax, abdominal cavity, or skin. The placenta is markedly edematous, enlarged, and buggy. It contains large, prominent cotyledons and edematous villi. Pleural effusion may be so severe as to restrict lung development, which causes pulmonary compromise after birth. You remember that during pregnancy, main oxygenation of baby happens through the placenta and umbilical cord, and lungs are not working. But after birth, you understand, with the first breath in, baby's lungs should be opened, and if it does not happen, it leads to pulmonary compromise. Ascites, hepatomegaly, and splenomegaly may lead to severe labor dystocia because of too strong enlargement of abdominal circumference of intrauterine baby, because of abdominal swelling and ascites. And severe hydropic changes are easily seen with sonography. The precise pathophysiology of hydrops remain unknown. Theories include heart failure from profound anemia and hypoxia, portal hypertension due to hepatic parenchymal disruption caused by extramedullary hematopoiesis, and decreased colloid oncotic pressure resulting from liver dysfunction and hypoproteinemia. The data from several studies indicate that in most cases, the degree and duration of anemia is the major factor causing and influencing the severity of ascites. Secondary factors include hypoproteinemia caused by liver dysfunction and capillary endothelial leakage resulting from tissue hypoxia. Both of these lead to protein loss and decreased colloid oncotic pressure, which worsen hydrops. All fetuses with hydrops had hemoglobin values less than 38 gram per liter, plasma protein concentration less than 2 standard deviations below the normal mean, and substantive protein concentrations in ascitic fluid. Conversely, none of the fetuses with hemoglobin values exceeding 40 gram per liter were hydropic. Even through 6 to 10 also had hypoproteinemia of the same magnitude as the hydropic fetuses. Fetuses with hydrops may die in utero from profound anemia and circulatory failure. One sign of severe anemia and impending death is the sinusoidal fetal heart rate pattern. In addition, hydropic placental changes leading to placenta-megaly can cause preeclampsia. Ironically, the preeclamptic mother may develop severe edema mimicking that on the fetus, which is referred to as the Miro syndrome. And please remember, immune isoimmunization is a risk factor for preeclampsia. The live-born hydropic infant appears pale, edematous, and limp at birth and usually requires resuscitation. The spleen and liver are enlarged, and there may be widespread ecchymosis or scattered petechia. Dyspnea and circulatory collapse are common. Perinatal mortality. Perinatal deaths from hemolytic disease caused by de-isoimmunization have decreased dramatically since adoption of the policy of routine preventative administration of D-immunoglobulin to all D-negative women during or immediately after pregnancy. Survival also have been increased by antenatal transfusions or preterm delivery of affected fetuses if necessary. The advent of fetal transfusion therapy has resulted in survival rates exceeding 90% for severe anemia alone and 70% if hydrops has developed. Identification of the isoimmunized pregnancy. So I repeat that not every D-negative woman is pregnant with a D-positive baby develops isoimmunization. So how we determine it happens? It is routine practice to perform blood typing and antibody screen at the first prenatal visit, and unbound antibodies in maternal serum are detected by the indirect Coombs test. If positive, specific antibodies are identified and the immunoglobulin subtype is determined as either immunoglobulin G or immunoglobulin M. Only immunoglobulin G antibodies are concerning because immunoglobulins M antibodies cannot cross the placenta. If the immunoglobulin G antibodies are known to cause fetal hemolytic anemia, the titer is quantified. The critical titer is the level for the particular antibody that requires further evaluation. This may be different for each antibody and is determined individually by each laboratory. The critical titer for anti-D antibodies is usually 1 to 16. Thus, a titer of 1 to 16 indicates the possibility of severe hemolytic disease. The critical titers for other antibodies are often assumed to be 1 to 16 as well, although most laboratories have insufficient data to support this assumption. An important exception is kill sensitization. The critical titer for anti-kill antibody is 1 to 8 or even less, as discussed in kill antigen. Determining fetal genotype. The presence of maternal anti-D antibodies does not necessarily mean that the fetus will be affected or is even D positive. This may be for several reasons. A half of all fetuses with antigen positive fathers and are D antigen negative because half of D positive males are D antigen heterozygotic, so they can donate as D positive and D negative chromosomes. Moreover, many women sensitized to non-D red cell antigens become immunized after a blood transfusion, and the antigen may not be present on paternal erythrocytes. Examples include other CE group and kill antigens. Determining zygosity of the father for the D antigen is helpful, and DNA-based analysis will establish this. But students, pay attention. Before paternal testing is pushed, it is imperative that any possibility of non-paternity be disclosed. If the father is homozygous for D, then there is a 100% chance of a D positive fetus, and fetal genotyping is not necessary. If the father is heterozygous, or if paternal DNA-based testing cannot be performed, fetal genotyping is performed on samples of chorionic villus amniocytes or fetal blood testing. Reference laboratories are also able to analyze amniocytes for E big, C small, kill, KIT, M big, and DAFI antigens. Non-invasive fetal D genotyping by using cell-free fetal DNA in maternal plasma is currently used in some European countries. Fetal DNA from maternal plasma or fetal cells is 85 to 95% accurate for D antigen determination. And of course, such non-invasive examination is essential because invasive procedures like amniocentesis, chordocentesis, or chorionic villus sampling can provide isoimmunization in D antigen in the moment of procedure if it was not done before. Management of isoimmunization. So, of course, management should be individualized and consist of the following measures. First one, it is maternal antibody titer surveillance. Second one, sonographic monitoring of the fetal middle cerebral artery peak systolic velocity. It's a Doppler velocimetry. Next one is amniotic fluid bilirubin studies. It can be done with the repeated amniocentesis, or fetal blood sampling, which can be done with the chordocentesis. Accurate pregnancy dating is critical. The gestational age at which fetal anemia developed in the last pregnancy is important because anemia tends to occur earlier and be sequentially more severe. In the first sensitized pregnancy, a positive antibody screen with a titer below the critical level should be followed with repeated titers at timely intervals, usually monthly. Once the critical titer has been met or exceeded, subsequent titers are not helpful and further evaluation is required. If this is not the first sensitized pregnancy, then the pregnancy is considered to be at risk and maternal antibody titers are unreliable. Middle cerebral artery or MCA peak systolic velocity. In more specialized centers, serial measurement of the peak systolic velocity of the fetal middle cerebral artery has replaced amniocentesis for detection of fetal anemia. The anemic fetus shunts blood preferentially to their brain to maintain adequate oxygenation. The peak middle cerebral artery systolic velocity increases because of increased cardiac output and decreased blood viscosity, and blood viscosity decreases because of hemolysis and anemia development. So a threshold of more than 1.5 mom correctly identified all fetuses with moderate or severe anemia. If the middle cerebral artery peak systolic velocity exceeds 1.5 mom, the fetus is likely to be anemic. Further evaluation by the fetal blood sampling is then necessary to determine the need for blood transfusions. And here on the pictures you can see results of middle cerebral artery peak systolic velocity. It's a Doppler velocimetry. On the left above picture, you can see the visualization of middle cerebral artery with measurement of peak systolic velocity in it. On the below you can see criteria. And the highest is PCV, it's a peak systolic velocity. Ultrasound diagnostics. In order to identify the first signs of hemolytic disease of the fetus, ultrasound should be performed starting from 18 to 20 weeks. Until then, ultrasound signs of hemolytic fetal disease usually are not defined. Repeated ultrasound is performed in 24 to 26 weeks, next one 30 to 32 weeks, next one 34 to 36 weeks, and immediately before delivery. So usually we do it with time interval 2 to 4 weeks. But if necessary, the interval between the studies is reduced to 1 to 2 weeks, but in severe forms of the hemolytic fetal disease, ultrasound performed every 1 to 3 days. In severe fetal hydrops are noted following symptoms. And pay attention, students, if we reveal that symptoms, it means main time is lost. Hydrops fetalis always indicate in severe condition of baby and decreased prognosis for life and health. So symptoms of severe fetal hydrops are hydropericardium, and it is one of the earliest symptoms, ascites and hydrothorax in conjunction with hydramnios, very unfavorable prognostic sign. Cardiomegaly, swelling of the scalp, and especially pronounced areola sign and skin of extremities. In case of areola sign, it is so-called double fetal head contour. Next sign is poor contractility and ventricular wall thickening. They are signs from the side of heart. Next one is increase in echogenicity of the intestine due to the swelling of its walls. Hypertrophied and thickened swelling of the placenta. The structure of placenta is homogeneous. Unusual position of the fetus known as the posture of Buddha, in which the spinous extremities of the fetus are withdrawn from the swollen belly, and body and head is extended, extremities are pressed back because of very big swollen belly and ascites. Overall reduction in motor activity that is characteristic of a fetus with severe hemolytic disease. On the severity of hemolytic disease of the fetus, ultrasound signs indicate the following: extension of umbilical cord vein more than 10 mm in diameter, including an increase in the diameter of its intrahepatic department. Increase in the vertical dimension of the liver compared with gestational norm. It happens because of swelling and edema of the liver. Thickening of placenta. Normally it is 0.5 to 1 cm, and in this case it should be more. And thickening of placenta, the same as happens because of its swelling and edema. Next is increase in the rate of blood flow in the descending aorta of the fetus. The rate varies inversely with the level of fetal hemoglobin. Increase in the maximum systolic blood flow velocity in the middle cerebral artery of the fetus, as we discussed before. And here on the pictures you can see different ultrasound signs of hydrops fetalis. On the upper left picture you can see very thick enlarged placenta with homogeneous consistency, and pay attention, this placenta is measured to be 48 millimeters thick. Normally, you know, it is less than 1 cm. In the upper right picture you can see hydropericardium, it's a small number of fluid near the heart, and hydrothorax, collection of fluid in thoracic cavity. That black color around the heart indicates collection of collection of fluid. In the low left picture, the same is present, hydropericardium. Yes, near the four chambers heart, you can see additional collection of fluid which is marked and measured, and it is presence of hydropericardium. In the low right picture, you can see the baby with enlarged abdomen. Around the liver and inside abdominal cavity collected extra fluid, it is ascites. And if you pay attention to the spinal column of baby, it is extended, so it is the posture of Buddha. On these pictures you can see visualization of so-called areola sign. In the left picture you can see baby's profile and double contour which is visible. Internal contour, it's the baby's skull, and external contour is the baby's head skin. Between them are located swollen subcutaneous fat. And even better, it is visualized on the right picture, where you can see oval shape baby skull, its internal contour. After that, edematic fat, and second contour is baby's head skin. So here you can see so-called areola sign. The functional state of the fetus in pregnant women with rhesus syncytization evaluated using cardiotocography and fetal biophysical profile, which is advantageously carried out in an outpatient setting ranging from 32 weeks gestation until delivery. If there are signs of chronic distress, monitoring should be carried out on a daily basis for early detection of deterioration of the fetus. When cardiotocography marked characteristics of fetal distress changes, the severity of which increases with increasing severity of hemolytic disease of the fetus. Registering the cardiotocography curve sine wave type indicates the presence of hydropic forms of hemolytic disease and the critical condition of the fetus. If any significant immunization titers in previously immunized pregnant, the next stage of the diagnosis is amniocentesis. Indications for amniocentesis are complicated obstetrical history, complicated by antenatal fetal death, intranatal fetal death, and postnatal deaths of children from severe hemolytic fetal disease. Next one is the presence of children who underwent exchange blood transfusion in connection with the hemolytic fetal disease and hemolytic disease of newborn. Next one is detection of ultrasound markers of hemolytic fetal disease. And last one is level of antibody titer 1 to 16 or higher. Given that the hemolytic disease of the fetus rarely develops before 22 to 24 weeks of pregnancy, amniocentesis before that date impractical. The obtained amniotic fluid, 10 to 20 milliliters, is quickly transferred to a dark container and after centrifugation and filtration is subjected to spectrophotometric analysis. And students, pay attention. Received amniotic fluid is very important to put into the dark container as soon as it's possible because light distract bilirubin, which is located in amniotic fluid. So here on the picture you can see scheme and real photo of amniocentesis. It should be done under the ultrasound guide and echo-positive marker needle is used for puncture. With the ultrasound, we choose the best place for synthesis, where all main vessels and placenta is far, and amniotic sac should be punctured with receipt of 10 to 20 milliliters of amniotic fluid. Amniotic fluid spectral analysis should be done. Almost 50 years ago, Dr. Lilly demonstrated that the utility of amniotic fluid spectral analysis to measure the bilirubin concentration, to estimate the severity of hemolysis, and thus to indirectly assess anemia. It is less widely used now, but is recommended its parallel use initially with middle cerebral artery Doppler flow studies to verify accuracy as centers gain experience with velocimetry. It is also used when Doppler velocimetry is not readily available. And because amniotic fluid bilirubin levels are low, the concentration is measured by a spectrophotometer and is demonstrable as a change in absorbance at 450 nanometers light. This difference is referred to as optical density 450 indexed. The likelihood of fetal anemia is determined by plotting the optical density indexed 450 value on a graph that is divided into several zones. The original Lilly graph is valid from 27 to 42 weeks and contains 3 zones. Zone Y generally indicates D negative fetus or one with only mild disease. If baby's results pass into the zone 1, it means pregnancy can be normally continued until there are more mature terms or even full term with only observation. Zone 2 indicates that anemia is present. In lower zone 2, the anticipated hemoglobin level is 110 to 139 grams per liter, whereas in upper zone 2, hemoglobin values range from 80 to 109. And students, pay attention. Hemoglobin norms for newborn infant just after birth is character 160 to 180 grams per liter. Zone 3 indicates severe anemia with hemoglobin values below 80 grams per liter. And use of the Lilly curve allowed decisions regarding management. So here you can see a picture of standard Lilly curve. Now it is measured by 14 to 40 weeks. And in horizontal scale are put weeks of gestation, onto vertical scale optical density indexed 450 nanometers. And here you can see highest zone intrauterine death risk, high second zone rhesus positive, low undeterminate, and the lowest zone rhesus negative or unaffected baby. More detailed information can be obtained directly in the study of fetal blood obtained by chordosynthesis. Blood from the umbilical cord taken by aspiration needle introduced under the transabdominal ultrasound guidance. The method allows defining the following parameters in the fetus: blood group and rhesus factor, hemoglobin and hematocrit, antibodies associated with fetal red blood cells by the direct Coombs test, bilirubin level, number of reticulocytes, blood serum protein, and acid-base status. So with the help of chordosynthesis we directly receive fetal blood and of course can determine every necessary criteria. Chordosynthesis particularly important in women with a prior rhesus immunization, when the level of antibodies cannot be a criteria for evaluating the severity of fetal hemolytic disease. Here on the picture you can see scheme and real photo of chordosynthesis. Under the transabdominal ultrasound guidance, special needle puncture the cord vein near the placenta, because in that region the cord vein is the widest, and to exclude baby's traumas and technical problems, we immobilize baby by giving myorelaxants for short time. What is the management of pregnancy depending on the test results? At gestational age of more than 34 weeks, if the patient has a delta optical density 400 nanometer in zone 3 or fetal hematocrit level is below 30%, as well as ultrasound signs of fetal hydrops, should be undertaken delivery. At gestational period less than 34 weeks, under similar indices of intrauterine blood transfusion is required or delivery. If gestational age less than 34 weeks, the fetal lungs immature, and there is a possibility for intrauterine transfusion, then proceed to their implementation. Fetal blood transfusions. With evidence of fetal anemia, hepatomegaly, or hydrops, or with non-reassuring fetal testing, management is determined by gestational age. The near-mature fetus should be delivered. The preterm fetus can be evaluated using fetal blood sampling, and transfusions are given as necessary. Fetal hemoglobin, hematocrit, reticulocyte count, and indirect Coombs titer are determined to predict the onset of anemia if the fetus is not yet affected. Transfusions would be commenced when the hemoglobin level is at least 20 grams per liter below the mean for normal fetuses of corresponding gestational age, and when the fetal hematocrit is below 30%, so 2 standard deviations below the mean at all gestational ages. As a rule, to predict the next transfusion, the fetal hematocrit decreases 1 volume% per day. With severe early onset hemolytic disease, intraperitoneal transfusions are done because it is technically difficult to gain vascular access in the cord. Because of extreme prematurity of co-students and low size of baby and its umbilical cord and cord vessels. With an older and larger fetus, most prefer intravascular transfusions, which are done the same through the chordocentesis. Transfusions is performed at an initial rate of 1 to 2 ml per minute and gradually bringing the rate to 10 ml per minute. Before and after the transfusion of red cells, determine fetal hematocrit. Desired final hematocrit after transfusion is 45%. In severe anemia, with a hematocrit below 30%, of transfusion allows to maintain the hematocrit at a level close to normal, which is 45 to 50%. Requirements for red blood cells for transfusions. They are blood group O, rhesus negative, tested negative for the virus and hepatitis B and C, cytomegalovirus and HIV, compatible with the mother and fetus, and washed free in saline to minimize the risk of viral contamination. Delivery. The goal of management is delivery of a reasonably mature, healthy fetus. When management includes serial amniotic fluid optical density indexed 450 measurement or fetal transfusions, fetal well-being should be closely monitored. According to the American College of Obstetricians and Gynecologists, with appropriate management, extremely preterm delivery usually can be prevented. Caesarean section is recommended in case of hydrops fetalis. This is because of high risk of cephalopelvic disproportion or fetopelvic disproportion, because of swelling fetal head and swelling and edematous ascitic abdomen. Neonatal care and outcome. Some advocate that the last transfusion for the severely affected fetus be given at 30 to 32 weeks with antenatal corticosteroid administration and delivery at 32 to 34 weeks. Others continue transfusion until 36 weeks. And really, you remember that in every case of risk of premature labor, we need to use prophylaxis of respiratory distress syndrome by administration of antenatal corticosteroids or dexamethasone or betamethasone to improve maturation of fetal lungs. In either case, cord blood is obtained at delivery for hemoglobin concentration and direct Coombs testing. If the infant is overtly anemic, it is often best to complete the initial exchange transfusion promptly with recent collected type O D negative red cells. For infants who are not overtly anemic, the need for exchange transfusion is determined by the rate of increase in bilirubin concentration, the maturity of the infant, and the presence of other complications. Most fetal transfusions survivors develop normally. Use of special prophylaxis anti-D immunoglobulin. De-isoimmunization is prevented by administration of high-titer anti-D antibodies extracted by cold alcohol plasma transfusion and ultrafiltration. A standard intramuscular dose provides 300 grams of D antibody as determined by radioimmunoassay. It is given to the D-negative non-sensitized mother to prevent sensitization after pregnancy-related events that could result in fetal maternal hemorrhage. All through sensitization can follow spontaneous miscarriage as well as early elective pregnancy termination. The precise incidence is not known. Still, most recommend that D-negative women receive anti-D immunoglobulin. A 50-gram mini dose is available for these early pregnancy indications. Routine antepartum administration. One dose of anti-D immunoglobulin is given prophylactically to all D-negative women at approximately 28 weeks, and a second dose is given after delivery if the infant is D positive. So D status of newborn infant should be determined soon after baby birth. Regardless of antepartum administration, at 28 weeks, a second dose is required after delivery because the half-life of immunoglobulin is only 24 days and protective levels predictably persist for only 6 weeks or so. D-negative women who received blood products are also at risk of becoming sensitized. Although they should be given only D-negative red cells, platelet transfusions and plasmapheresis can provide sufficient D antigen to cause sensitization. This can be prevented by an injection of D immunoglobulin, and most recommend routine administration when there is blunt maternal trauma, although its necessity had not been proven. In many cases, anticipated fetal-maternal hemorrhage is mild and likely protected by the 28-week dose of immunoglobulin. Still, when there is doubt about whatever to give anti-D immunoglobulin, it should be given. Even if not needed, it will cause no harm, but failing to give if they need it can have severe consequences. Large fetal to maternal hemorrhage. With more severe fetal maternal hemorrhage, one 300-gram dose of D immunoglobulin may not be sufficient. In extra D immunoglobulin, is considered only for women with risk factors such as abdominal trauma, placental abruption, placenta previa, intrauterine manipulation, multifetal gestation, or manual removal of the placenta. Half of women requiring more than the 300-gram dose would be missed. The American Association of Blood Banks recommends that all D-negative women be tested at delivery with the Klein-Hauer-Betke or Z test. The dosage of anti-D immunoglobulin is calculated from the estimated volume of the fetal to maternal hemorrhage. One 300-gram ampulla is given for each 30 milliliters of fetal whole blood to be neutralized. Here on the picture you can see result of Klein-Hauer-Betke or Z test. After color, bright pink fetal cells are likely to be collected on the background of pale maternal so-called ghost cells. With calculating the fetal erythrocytes, it's more possible to determine the number of fetal blood passing to mother's circulation and to calculate correct dosage of anti-D immunoglobulin. So finally, every D-negative woman should receive 1 or 2 dosages of anti-D immunoglobulin, which is 300 grams, after every termination of pregnancy by miscarriage, stillbirth, preterm delivery, in-time delivery, post-term delivery, cesarean section, elimination of ectopic pregnancy, and the same after the cases obstetrical complications, increasing the risk of fetal to mother hemorrhage. But possible maternal to fetal hemorrhage. It is now recognized that in virtually all pregnancies, small amounts of maternal blood enter the fetal circulation. Unlike fetal to maternal bleeding, physiologically significant maternal to fetal hemorrhage is uncommon. But rarely the D-negative fetus is exposed to maternal D antigen and becomes sensitized. When such a female fetus reaches adulthood, she will produce anti-D antibodies even before or early in her first pregnancy, because she was sensitized by blood of her mother intrauterine. This mechanism of isoimmunization is called the grandmother theory, because the fetus in the current pregnancy is jeopardized by antibodies initially provoked by its grandmother's erythrocytes. Major blood group ABO incompatibility offers appreciable protection against desensitization of the fetus. D-negative infants born to D-positive mothers are not routinely given D-immunoglobulin prophylaxis. And all these changes result in hemolytic disease of the newborn. If untreated hemolytic disease of the fetus after birth developed hemolytic disease of the newborn, which can be represented by or just hemolytic anemia, jaundice with hemolytic anemia, or hydrops with hemolytic anemia and jaundice. And on the picture you can see baby with jaundice with exactly yellow color of the skin and mucous membranes. Hemolytic disease of the fetus and newborn, and its synonym is fetal erythroblastosis or erythroblastosis fetalis, is classified by 3 degrees depending on the severity of hemolysis and the ability to compensate for fetal hemolytic anemia without developing hepatocellular lesions, portal obstruction, and generalized edema. There are mild hemolytic disease, occupy half of all Parton's fetuses, moderate occupy 25 to 30%, and severe occupy 20 to 25%. Mild disease hemoglobin concentration in cord blood, which is 120 gram per liter and more, and normal is 160 to 180 gram per liter. Moderate hemolytic disease is character for hemoglobin level 70 to 120 gram per liter, and for severe hemolytic disease, hemoglobin is below 70 gram per liter. The criteria for the diagnosis of hemolytic disease of newborn are: first one, birth of a child with generalized edema and anemia with hemoglobin below 120 gram per liter and hematocrit less than 40%. Next one, appearance of jaundice staining of the skin of the child in first day after baby birth and the positive Coombs test. And last one, appearance of pale color of the skin in first day and laboratory confirmation of anemia with hemoglobin below 135 gram per liter and hematocrit below 40% and increase in reticulocytes. Hyperbilirubinemia. Unconjugated or free bilirubin is readily transferred across the placenta from mother to fetus if the maternal plasma level is high. Kern icterus. This condition may result from unconjugated hyperbilirubinemia in the newborn, especially if preterm. Bilirubin deposition and staining in the basal ganglia and hippocampus result in profound neuronal degeneration in these regions. Surviving infants show spasticity, muscular incoordination, and varying degrees of mental retardation. There is a positive correlation between unconjugated bilirubin levels above 180 to 200 mg per liter and kern icterus. Despite this, kern icterus may develop at much lower concentrations, especially in very preterm infants. In a follow-up study from the Collaborative Perinatal Project, levels of total serum bilirubin 250 mg per liter correlated with kern icterus only in those infants with a positive Coombs test. Physiological jaundice. By far, the most common form of unconjugated non-hemolytic jaundice is so-called physiological jaundice. In the mature infant, serum bilirubin usually increases for 3 to 4 days to levels up to 100 mg per liter, and then concentrations fall rapidly. Perhaps 15% of infants are diagnosed with jaundice. In preterm infants, the rise is greater and more prolonged. And this jaundice is caused by natural destruction of fetal hemoglobin and its transformation to normal adult hemoglobin. Hemoglobin F breaks and hemoglobin A start to be determinable. Classification of newborn jaundice at the time of appearance include following variants. First one, early jaundice, which occurs up to 36 hours of life. Jaundice appearing in the first 24 hours, it is always a sign of pathology. So-called physiological jaundice appears after 36 hours of life and is characterized by increased levels of bilirubin no more than 205 mmol per liter. Complicated physiological jaundice is physiological jaundice during which can be accompanied by a change in the child's condition. So-called prolonged or protracted jaundice, which is determined after 14 days of life in term infants and after 21 days of life of a premature baby. Late jaundice that appears after 7 days of life of the newborn. Then jaundice always requires careful examination. And what is the treatment for hemolytic disease of newborn? The main goals of therapy include preventing the development of central nervous system as a result of the central nervous system damage as a result of the toxic effects of bilirubin, and warning of severe hemolytic anemia. Methods of treatment are phototherapy and exchange blood transfusion. Phototherapy is now widely used to treat hyperbilirubinemia because light increases oxidation of bilirubin. This enhances renal clearance and lowers serum bilirubin levels. Light that penetrates the skin also increases peripheral blood flow, which further enhances photooxidation. And rarely exchanged blood transfusion is required. And on a picture you can see the procedure of phototherapy. Baby is located in a special cuvette under the source of ultraviolet light with exactly protected eyes, and cardio monitor put it on the heart region to control the baby's well-being. Exchange blood transfusion. Immediate exchange transfusion is recommended in infants showing signs of acute bilirubin encephalopathy, or if total serum bilirubin is equal or higher than 85 micromole per liter above these levels. The final decision to perform an exchange transfusion will be made by the consultant neonatologist and will be based on the guidelines as well as the following: trend of serum bilirubin levels and response to treatment, clinical presentation of infant, which includes signs of bilirubin encephalopathy, underlying condition, and previous treatment as referring hospital at applicable, including in utero management or underlying condition. In utero management, it means intrauterine blood transfusion. And blood volumes are used for transfusion. The volume of blood for exchange transfusion is calculated using an estimate of the neonate's circulating blood volume. For term infants, it is determined in formula 80 milliliters per every kg. For preterm infants, 100 milliliters for every kg. Here you can see the picture how happens exchange blood transfusion. You can see that baby is located under the special source of ultraviolet light with protected eyes. Present possibility to auscultate fetal heart sounds and lung sounds. Into the umbilical vein put it venous catheter, and two injectors or 2 tubes are added to that catheter, one to give blood in, one to take blood out. Complications of the procedure of exchange blood transfusion include catheter-related complications. It can be air embolism, thrombosis, or hemorrhages. Hemodynamic complications related to excess removal of injection of blood include hypo or hypertension, intraventricular hemorrhage, especially character for preterm newborn infants, hypo or hyperglycemia, hypocalcemia, hyperkalemia and acidemia, arrhythmias, bradycardia, neutropenia, delusional coagulopathy, feed intolerance and necrotizing enterocolitis, septicemia, blood-borne infections, and hypo or hyperthermia. So, post-procedure care of the infant include following management: continuously monitor vital signs and record 30-minutely for first 4 hours post-procedure. Perform blood glucose levels immediately post-procedure and then hourly until stable. Measure serum bilirubin levels on the hour post-exchange transfusion and repeat 6 hourly. Continue phototherapy until bilirubin levels are within acceptable range. Observe catheter sites for signs of bleeding and hemorrhages. Keep infant for at least 4 hours post-exchange transfusion or longer at the direction of the medical officer. As exchange transfusion carries a potential risk of necrotizing enterocolitis, we should monitor the appearance of the abdomen and the presence of bowel sounds. Observe for signs of feed intolerance when feeding is recommended. We should measure urea and electrolytes, full blood examination, hematocrit and blood gas on a regular basis until infant stable, as directed by a medical officer. And the medical officer performing the exchange transfusion should document the procedure in the progress notes. Students, thank you for your attention. Our lecture is over and goodbye.